Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Diarrhea. It can range from just a minor problem to a full-blown, life-threatening emergency. So today, we're diving deep into the pharmacology of antidiarrheal drugs and rehydration therapies. The goal here is to give you a solid foundation to manage this condition and, of course, to absolutely crush these concepts on your exams.
So here's our game plan. First, we'll talk about why diarrhea can be so dangerous. Then, we'll hit the number one priority, and I mean number one, rehydration. After that, we'll get into the drug classes themselves, and we'll wrap it all up with some high-yield takeaways to make sure this all sticks.
All right, let's really reframe how we think about this. Diarrhea isn't just about feeling uncomfortable or making a few extra trips to the bathroom. In serious cases, especially for the very young or the elderly, that rapid fluid loss can spiral into severe dehydration, electrolyte chaos, kidney failure, and yes, even death. That's why knowing how to handle it is just so critical.
So what is it fundamentally? At its core, diarrhea is just a massive state of fluid and electrolyte imbalance. The body is literally dumping water and crucial salts like sodium and potassium way faster than it can absorb them. And that imbalance, that's the real enemy we have to fight.
This number right here really puts it into perspective. 100 milliliters per kilogram. That means a patient has lost 10% or more of their total body weight in just fluid. I mean, we're not just talking about being a little thirsty here. This is a true medical emergency, one that can lead to hypovolemic shock if we don't act fast.
So this lays out our management strategy, and you have to pay attention to the order. It is absolutely crucial. Job number one, always, is to replace those fluids and electrolytes. Get the patient stable. Only then can we start thinking about treating the cause and maybe using some medications to help with the symptoms.
Okay, so we all agree rehydration is key. But how does it actually work? Because it's a bit more clever than just telling someone to drink a glass of water. There's this really elegant physiological trick at play here, and once you understand it, treatment makes perfect sense.
So you might be looking at an oral rehydration solution and thinking, wait, why are we giving a sick person sugar? It seems a little counterintuitive, right? Well, there's a brilliant reason for it, and it all happens at the molecular level.
The hero of this story is a little protein called SGLT1. The best way to think about it is like a bouncer at a club that's on the intestinal wall. This bouncer will only let sodium in if it brings a friend, and its +1 is always glucose. The truly amazing part? Even when the gut is being ravaged by an infection, this SGLT1 system just keeps on working.
And here's how it all comes together. Sodium and glucose show up, bind to the SGLT1 transporter, and get pulled into the cell together. This sudden rush of solutes inside the cell creates a powerful osmotic gradient, and water, well, it just follows the party. It gets drawn from the gut right into the cell, and just like that, the body starts to rehydrate itself. It's simple, but so incredibly effective.
Okay, clinical decision time. For most of your mild to moderate cases, the WHO's oral rehydration solution, or ORS, is your absolute go-to. But if things are severe, you're going to need IV fluids. Normal saline's great for just filling the tank quickly, but Ringer's lactate is often a better choice because it's a more balanced solution. It gives you potassium and a buffer. Now, here's a clinical pearl for you. Be careful with Ringers in patients with really bad liver disease, since they might struggle to metabolize that lactate.
All right, our patient is rehydrating. Now we can think about managing those symptoms. And one of the best ways to do that is with anti-motility agents. And believe it or not, the secret to how they work has everything to do with the opioid family of drugs.
So what's the mechanism here? Well, these drugs go right for the mu-opioid receptors that are located in the gut's own nervous system. Activating these receptors is like slamming on the brakes. It shuts down peristalsis, those long wave-like contractions that push things forward. At the same time, it actually increases these churning, mixing movements. The result? Everything slows way down, giving the gut way more time to suck water and electrolytes back into the body.
Now, for your exams, you've got to know the two big players here, loperamide and diphenoxylate. Loperamide is the one you can buy over the counter. Why? Because its pharmacokinetics keep it stuck in the gut. It doesn't really cross the blood-brain barrier, so there's very little risk for abuse. Diphenoxylate, on the other hand, can get into the central nervous system at high doses, so it's a prescription that's usually mixed with atropine, which makes taking too much of it a pretty unpleasant experience.
Okay, this is a huge red flag, a major contraindication you have to know.
Never, ever use these drugs if you even suspect an invasive bacterial infection. We're talking high fever, bloody stool. Why? Because by slowing the gut down, you're essentially trapping that dangerous pathogen inside. You're giving it time to multiply and potentially cause a deadly condition called toxic megacolon.
So we've talked about slowing things down. But what if we could go after the problem more directly? Well, that's exactly what our next class of drugs does. Instead of just affecting motion, they work to neutralize the very toxins and bugs causing the problem in the first place.
The best way to think about these agents is as tiny molecular sponges. They don't get absorbed into the body, they just travel through the gut, and their massive surface area allows them to bind up or adsorb things like bacterial toxins. Once they've latched onto the bad guys, they just carry them right out of the body.
And the prototype here, the one you absolutely have to know, is bismuth subsalicylate. This stuff is a real powerhouse. It's got a 1-2 punch. The bismuth part coats the gut and grabs onto toxins. Meanwhile, the salicylate part gets absorbed and works to reduce fluid secretion. That dual action makes it perfect for travelers' diarrhea. And don't forget the classic, totally harmless side effects, a black tongue and black stools. Oh, and a huge exam pearl. Because of that salicylate, you avoid this in kids with a viral illness because of the risk of Ray's syndrome.
All right, we've covered a ton of information, so let's pull all of this together and really hammer home the key takeaways. And I've got a bonus drug for you, one that's perfect for those tricky, specialized questions you might see on an exam.
And here it is, octreotide. Think of this as the specialist, the big gun you bring out for really severe, high-volume secretory diarrheas. We're talking about the kind caused by hormone-secreting tumors. As a somatostatin analog, its whole job is to just powerfully shut down the release of those hormones, turning off the faucet that's causing the gut to pour out all that fluid.
Look, if there is one single thing you remember from all of this, let it be this. Rehydration is king. Always, 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 your first priority is fixing the patient's fluid and electrolyte status. Everything else, all the other drugs we talked about, is secondary. And whether you use them depends entirely on the situation.
Okay, let's wrap it up with a quick clinical case to lock it all in. A patient on vacation gets a classic case of traveler's diarrhea. Which drug are you reaching for? Which one has that unique dual action, where it can bind toxins and reduce secretions? If you know the answer to that, you're in great shape to master the pharmacology of antidiarrheals.